Hi, my name is Cindy Mays, and I am a volunteer with Know the Glow. We are a nonprofit, and our whole mission is to create awareness about childhood blindness and raise awareness about the glow, which is medically called leukocoria. So now I'm going to show you a video about the glow.
I'm Isaiah's grandmother, and this is the glow.
I'm her older sister, and you can see it right here.
Every 60 seconds, a child goes blind.
It was in his right eye.
And his left eye.
Was in her right eye and her left eye.
Yet most blindness can be prevented.
Right here.
You could barely see it.
Just look for the glow in flash photos of your children.
It was really just a small glow.
And we had no idea that it was cancer.
Go to knowtheglow.org for more information.
I'm so glad we found it.
I'm going to talk about that same white pupil that those children showed with their families that had revealed they had cancer in their eye. But I'm going to go into the eye and show you what we see when we look in to document the tumor and to treat it. You can see the white pupil in this child's both eyes, and this eye is drawn here in the conventional standard way that since the 1950s, we've always drawn retinoblastoma on a piece of paper with that circular background. Retinoblastoma active is always yellow and retinal detachment is always blue. The tumors actually look white, but in the drawings, they're always yellow. And you can see this big lump here. There's the center of vision. Not the center of vision, the optic nerve. The center of vision's right here where the X is. And you can see this would represent that tumor, which causes that white pupil up towards his nose and up. The other eye is much more full of tumor, bigger tumor, total retinal detachment, and you can see that illustrated in the picture here. But you can realize that these pictures just take a little snapshot in the middle, whereas the drawing and the coding of active tumor by the color yellow shows us everything that's going on in the back of this child's eye. So he has bad bilateral retinoblastoma showing up as leukocoria. This is the Depict Health timeline that we use to record all the treatments this child has had. And this is the right eye and its staging and the cancer staging, and the left eye. And I'm showing you the drawings you just saw of this child's two eyes at the moment of his initial diagnosis. He was then treated with 5 cycles of systemic chemotherapy. And on this diagram, it shows that going across both eyes because it's given to him intravenously. So it goes to his whole body and affects both eyes. Arterial chemotherapy is the red triangle, and it only goes to one eye, etc. So this is all the things that happen to the right eye and the left eye. So after all this treatment, and he'd lost one eye, and the remaining eye had a bit of a mess. All the yellow in here is 30 small tumors, and the calcified tumor had recurred and grown again, although it had initially responded to some extent. And then Then I went to a meeting where I met Lynn Murphy, who had led the Retinoblastoma Program at Children's Hospital LA, and he told me that the chemo plaque, or the way to give chemo from outside the eye to inside the eye, had just achieved FDA approval to be used in children. I said, I have a patient who needs it, because the only other options for this child's eye, his only eye, were to remove it or to treat it with external beam radiation, which puts him at a lifetime risk for more cancers, and we try hard to avoid that. So this is the way chemotherapy is given to children. It goes intravenously, and that goes, all of the little yellow orange dots here represent chemotherapy given over a few minutes every 3 weeks. That some will get to the eye, but it also goes to the blood and knocks down the white cells, and to the hair, and the hair falls out, and all the complications we know about intravenous chemotherapy. Intraarterial chemotherapy is given through the ophthalmic artery by winding the way up from the groin into the ophthalmic artery by brilliant interventional radiologists. That exposes the tumor in the eye for a few minutes, approximately every 3 weeks. a little bit of the chemotherapy goes to the brain, and in some cases, quite a lot goes to the brain. We don't know what it does in the brain. And then intravitreal chemotherapy is given when there's recurrence in the vitreous, particularly, and that's been a big advance in treating that difficult part of the tumor because it doesn't have a blood supply in the vitreous. And that's again given over minutes every 3 weeks. The chemoplaque, or the sustained release chemotherapy put forward by the company 3T Ophthalmics, is a little silicone plaque that is for retinoblastoma glued to the sclera, no hole in the eye, no needles near the eye, and the drug, whatever the drug would be, in the chemoplaque diffuses into the eye. So it moves as those arrows indicate, and it keeps going over 42 days. That's a radical change to think of chemotherapy sustained over 42 or more days. And that is what it was very exciting to me to think that we should try that in our patient. So here he is again with his 30 tumors. We put the chemoplaque on here, and then we took it off, and by 20 days, which was about here, we took it off at 70 days. By 20 days, all the small tumors had disappeared. The calcified tumor had regressed. It had gotten a little smaller. You can see this part's a little smaller than this, and this little bulge is gone, but it didn't completely go away in that. And then with many more treatments to control, particularly the recurrences in this, we finally took out the calcium, and here he is now 2.5 years later with no end of tumor and good vision, and he's now a very happy Canadian kid. Here he is with his parents and playing in the snow and playing hockey and doing everything with vision. And we don't need any more anesthetics for him because he's doing so well. So we started a prospective clinical trial with the support and strong encouragement of 3T Ophthalmics at the Hospital for Sick Children for phase 1 sustained release topotecan, episcleral means outside the eye, plaque. We call it the chemoplaque for retinoblastoma, so it's called STEP-RB, the name of our trial. Its main purposes are to determine safety, to describe eye and systemic toxicities, and that's what phase 1 means. And then secondarily, to describe any anti-tumor efficacy. Only when we know it's safe can then we study in detail whether it actually is any good to cure the tumor. So here we are in now 2.5 years after we put the first chemoplaque in patient special access program patient 1, who I described. And all of these chemoplaques have had the 0.6 milligrams dose of topotecan. The next patient we put on the trial will go to 0.9 milligrams of topotecan because we've had no adverse events in any child in the eye or systemically. And we've had only one episode that our very strict monitoring committee says we must call a dose-limiting toxicity, but it was a very strange low white count, which is actually chronic in this particular child. In terms of efficacy, apart with the small tumors have all had a complete response. The progressive and recurrence tumors have occurred in calcified tumors, such as I showed you in patient's special access program, patient 1. So now we have 6 patients on the STEP-RB trial. The next one goes to a higher dose. And this is very exciting to us because we show that there's no toxicity, which is what you'd expect from a little silicone device glued to the outside of the eye and delivering a relatively small amount of drug, but sustaining that delivery of the drug over a longer period of time. So I'm very excited about this protocol. I'm excited to have this get bigger and to hear more about the other things that might be put into the chemoplaque to make this even more powerful for therapy. Thank you very much for your interest and support of this program.
Thank you so much, Dr. Gallie. That's really exciting results. And we look forward to seeing where this can go next. Thank you for joining us for this important discussion about retinoblastoma and the care for other ocular cancers. I'm going to be discussing the unique delivery platform with neuro-oncology implications. This is an application that can deliver not only the topotecan that you just heard Dr. Gallie elegantly discuss her experience with her retinoblastoma children, but likely we can not only treat retinoblastoma, but other ocular cancers, including ocular melanoma, and also prevent the scarring and cell death of the cells in your eye that allow you to see. So this episcleral delivery system can be placed in any quadrant, or you can place multiple systems such that you would have potentially 4 different systems, one protecting your cells, another making the fluid go away, and maybe 1 or 2 delivering a chemotherapeutic agent. It's a customizable drug delivery platform. It can be attached either using sutures if the patient doesn't have cancer, or with the cyanoacrylate glue that was mentioned, which is literally just super glue made in a very sterile delivery package to secure the episcleral device to the eye. It's very small, well tolerated, and it can deliver a wide variety of episcleral drug delivery. So at this point, there's 6 different FDA-approved molecules with many more in formulation and on the approval pathway. Topotecan is likely going to go to market and become available within the next year or so, depending on the regulatory pathway. Also, dexamethasone, bromonidine are in the pathway for approval. Dexamethasone and the other things like celecoxib and indomethacin are just like the things that you take for a headache or an inflammatory pain, but they're delivered to the eye to prevent fluid accumulation and scarring. Neuroprotection, we have bromonidine, and then an unnamed drug, it's called EC4565, and that's utilized to protect the cells, both the cells that help you see, but also the support cells that support the cells that make you see. The anticipation is that these potential clinical applications will include all malignancies of the eye, not only retinoblastoma and melanoma, but also lymphoma, adenoid cystic carcinoma, and other metastatic and primary malignancies, not only in the eye, but around the eye with modifications. We also hope to treat the refractory inflammation, fibrosis, and infiltration, which in other words, to simplify, is just to block the scars that limit vision, even if you have a completely successful elimination of the tumor. And then of course, to support the optic nerve and the retina so we can have the best possible visual outcome. The 3D Research Network includes a variety of locations. The currently active ones, not only Toronto Sick Kids with Dr. Gallie, but Stanford has just completed phase 1 recruitment for dexamethasone and has opened celecoxib phase 1. There are other IRBs in process and other IRBs in planning stages with clinical protocols. The most exciting is the MDM2. The MDM2 is something that augments the efficacy of a drug like topotecan, but also can work in conjunction with the anti-inflammatory mitigating agents and make them more effective, or work with Melphadex, which is melphalan, which is a chemotherapeutic that's mixed right in the same little capsule with dexamethasone. So it's very exciting, and we're looking forward to the next couple of years and certainly getting something moving forward so that we can help children as quickly as possible. This is just demonstrating the remarkable ability of the dexamethasone to eliminate this fluid collection. Within a matter of weeks, this fluid collection is dramatically diminished, and within a month, it's completely eliminated. So as you can imagine, the child that was shown with the extensive retinal detachments, if we could make the fluid go away quickly, that would be certainly helpful. So the impact on care, high efficacy, no systemic toxicity, and also importantly in the pandemic, lack of the systemic immune suppression. Negligible morbidity. My adult patients have described this as feeling sort of like an eyelash on the eye just for the first 24 to 48 hours. And finally, a wide applicability due to the simplicity, enabling a global reach to help patients not only in the United States and Europe, but patients in India and Africa, where the impact would definitely save lives in addition to saving eyes and vision. Thank you so much.
Hi, I'm Melody with the Cure Insight. We're a nonprofit for eye cancers, and we are excited to announce a fundraising initiative for the Episcleral patch. We have a donor who has put up $100,000 and will fund this research project if we can match that $100,000. This is where you come in. We need you to help us by making a donation of any amount so that we can reach $100,000. When we do that, we will take the pledged $100,000 that we already have, and we'll have a $200,000 donation that we could put to further research for retinoblastoma. But also, hopefully, this will transfer over to other ocular cancers, especially for ocular melanoma. Not being able to rely on radiation, which damages eyesight, is huge for the ocular melanoma community. So we're really excited that this is working for retinoblastoma. We hope that it will transfer to other ocular cancers and be a game changer. But we can only do this with your help. So please donate what you can and help us match the $100,000. Thank you so much.